Greetings, everybody. So glad you're here. I'm going to be talking about healthcare as a human right as a principled approach. To work for the right to healthcare and the bigger right to health, because these are human rights, which we all deserve, means much more than the slogan, healthcare as a human right. With a human rights approach, we choose an alternative vision of a decent society to the neoliberal nightmare that's being offered. Demanding healthcare as a human right puts us at the forefront of a countrywide movement which analyzes what's wrong with our healthcare system according to international human rights law principles. Government is required to respect, protect, and fulfill the right to healthcare, including by regulating private actors. The legal principles which define the human right to health care are globally accepted, even if our country has been slow to recognize them. Because leaders like Dr. King and social movements have been sidelined when they tried to organize for full human rights doesn't mean that we should give up. Studying social movements makes us realize how long it takes for a movement to come to fruition. A human rights movement means working against commodification of healthcare, which is eating away at the single-payer finance systems we do have, like Medicare and the VA. Human rights principles can be articulated and measured. Adherence to the principles can be compared between states and between political subdivisions of states like cities. The members of PNHP, its allies, and the public at large, which join this movement, can use human rights principles in organizing information about violations of the right to health care. We can call on our national government to account for its human rights record before the UN Human Rights Council and other treaty monitoring bodies. We can use these principles to organize for our ultimate desire a legal system that fully recognizes healthcare as a human right in statute, in judicial decisions, and administrative practice. The movement for healthcare as a human right is complementary to movements for democracy, for even basic majoritarian democratic attempts to regulate campaign financing, but more profoundly for movements for participatory democracy. Using the principles to organize and analyze the gap between the human right to health care and the reality can open up the debate about how we have allowed replication of unjust hierarchies and what we need to do to change. A fully functioning participatory democracy is the only guarantee for human rights, all human rights, including the right to health care. The first challenge in a principled approach is that health care is incorporated and guaranteed in law as a human right, something still to be achieved, although the state of Vermont has made some important history for us with their movement for health care as a human right and their new state law. Specific legally recognized principles constitute the elements of the right to health care. All of these principles are required. They're interdependent. A government can't pick and choose which principles are easier or the ones it prefers. Four elements make up the compound principle of universal access: universal, affordable, comprehensive, and equitable. The other principles are availability of care, acceptable and dignified care, equality and non-discrimination, quality of care, transparency and information access, participation, and accountability. Universal access to all health goods, services, and facilities requires that all human beings who reside in our country, no exceptions, have care. That care is affordable from the standpoint of the individual needing it, without such barriers as coinsurance, co-pays and deductibles, and free at the point of access, and not requiring the sacrifice of other human rights to get it. Universal access also requires the same comprehensive care, the full suite of goods and services for each person, not a tiered system. Universal access operates according to equity to ensure that care is provided according to the need of the person. Equity is important because it invokes the notion of citizenship rather than consuming, that we are all in the same society and responsible jointly for our public welfare. Equity embraces the idea that tailoring care to individual needs is humane and just. The principle of availability mandates that health infrastructure, goods, and services be within reach, regardless of where the person lives, be it city or tribal reservation. Availability looks at the numbers and distributions of doctors to deliver primary care. It does not allow the market to determine availability, and replaces that with regulatory law that serves all and ensures a system with incentives for primary health care in a system built on human rights principles. Another principle is that individuals should have acceptable and dignified care. Each person receiving care is deserving of respect, and the system can be designed to promote this. Care must be culturally appropriate. Another principle is non-discrimination and equality. All other principles of the human right to health care are conditioned on equality and non-discrimination. Non-discrimination refers to access as well as outcomes. The governmental duties run from respect to protection to fulfillment, moving from negative duties to increasingly more positive measures. A government respects non-discrimination in health care when it adopts and enforces laws which don't permit discrimination and mandate equal treatment, such as those prohibiting private actors from discriminating against women by denying reproductive health care like contraceptives. Grossly disparate maternal mortality rates for African American and Native American women requires government to step up to its duty to fulfill the right to equal health care and necessitates various special measures. Human rights principles broadly define who is entitled to protection from discrimination. People who are imprisoned and detained, all immigrants who reside in the U.S. regardless of documentation status, persons with disabilities. Discrimination is prohibited based on race, ethnicity, color, sex, sexual orientation, gender, language, religion, political or other opinion, property, meaning wealth, birth, national or social origin, health status. To guarantee the principle of quality, the human rights norm requires each country to offer the highest attainable standard for physical and mental health. It requires a minimum core of essential services. It does require nations to provide higher quality health care if they have greater resources. So the quality of care in the United States for each person should be higher than, for example, South Korea, the UK, Cuba, given relative GDPs. Finally, the principles of transparency, information access, and participation involve civil rights relating to freedom of expression, association, and assembly. Individuals need these rights, these principles, to realize the substantive right to health care. And of course, no human right would mean much if it didn't include the principle of accountability. Accountability means each person has a meaningful, appropriate, and prompt remedy when the healthcare system fails. It also requires fully functioning systemic mechanisms of accountability to the public. Thank you.
Okay, Dr. Philip Caper has come here from Maine to speak to us. He was trained initially at UCLA and then graduate medical work in Boston. He has held professorships in various areas in New England, and he has also been a professional staff member on the United States Senate Labor and Health and Human Resources Subcommittee on Health, Health that was chaired by the late Senator Edward Kennedy. Dr. Caper was a charter member of the nation's top healthcare advisory panel, the National Council on Health Planning and Development, from 1977 to 84, and chaired that panel for the last 4 years. He currently serves on the board of Maine All Care, which is a PNHP chapter in Maine advocating for a universal improved Medicare for All program for the state of Maine, and is a member of the National Board of Physicians for a National Health Program. Please join me in welcoming Dr. Phil Caper.
Okay, Sherry, thank you very, very much. I'm very, very pleased to be here and to return after many years to Washington State. I'm going to spend my allocated time this evening talking about why is this so hard to get done in the United States. You know, that's a question that I've been thinking about for some time. Most other wealthy countries have healthcare systems that cover everybody, so healthcare as a human right is a reality in almost every other wealthy country in the world. Their systems are much more popular with their publics, with their doctors, with their patients, and with their politicians than ours is. They have better outcomes according to international studies. The latest one released a couple weeks ago by the Commonwealth Fund. And by the way, they cost on average about half of what ours cost. So what's so hard to understand about that? You know, and what's going on here is my question. And so I'd like to talk a bit about what I call the underlying pathology of our healthcare system. Now, for those of you who are not physicians, let me explain for just a minute what underlying pathology means. Everybody knows what a sign or a symptom is. For example, if you have a skin rash, it could be caused by a number of things. Most skin rashes will respond to a steroid topical cream, at least temporarily. And they may be caused by a variety of things. They may be due to an allergy to the dye in your clothing, or it may be due to a drug you're taking, or it could be leukemia. Leukemia presents sometimes as a skin rash. So in order to treat not just the signs and symptoms, but the underlying disease, you have to understand what it is and diagnose what it is, because the treatments are very, very different. So I think that we have to look at the underlying pathology in our healthcare system, not just the signs and symptoms. The signs and symptoms are things like a large number of uninsured people. Medical bankruptcy is a leading cause of personal bankruptcy in our country, spotty quality, out of control costs, and so on. These are all symptoms. And in my view, the underlying pathology is something far deeper and more culturally important to Americans. For example, we're the only country in the world that treats healthcare as a business. And I saw that developing just as I was leaving Washington in the late 70s, where it became okay to think about healthcare as a business. What people didn't seem to understand is that the mission of a healthcare system and the mission of a business are very different. Okay, what's the mission of a business, any business? What do all businesses? Well, it's to create wealth for its owners. That's what they do. That's what they're all about. Do we really want a healthcare system whose primary mission is to create wealth for its owners? So that's one source of underlying pathology. And let me just know, so we shouldn't think of healthcare or accept the notion of healthcare as a business. It's something different. We also have to begin stopping talking about insurance and insurance reform as a way of financing healthcare. It's not that the insurance system needs to be better regulated, it's that it has to be eliminated because, because the fundamental business of insurance is slicing and dicing people into risk pools and then pricing policies to cover the risk. That's what they do. The biggest department in any insurance company is the underwriting department, and that's what these guys do all day. They're not doing anything wrong. They're doing what they know how to do, and what they're expected to do. And if they're for-profit companies, their focus is on the bottom line. And that's something that has to be understood. This is not a failure of the insurance business. This is a failure of public policy because we let them do it. So demonizing the insurance companies doesn't get you anywhere. They're just doing what they have to do, and we have to figure out a way to sort of ease them out of the picture entirely and replace them with a tax-based system. Finally, we have this love of marketplaces and competition. We want more competition. I read that every day. We need more competition in healthcare. Well, as a matter of fact, competition in healthcare doesn't work. We have a system that relies more upon competition and marketplaces than any other system in the world. And what do we have as a result? Out-of-control prices, large numbers of uninsured people, medical bankruptcies, spotty quality. That we have done that experiment and it has failed. So let's just recognize that and move on to something that actually works. And the reason marketplaces don't work in healthcare were explained very well by an economist at Berkeley named George Akerlof. And Professor Akerlof wrote a paper that won the Nobel Prize in economics, pointing out that in markets where there's a large asymmetry in information between the sellers and the buyers, in other words, the sellers know a lot more than the buyers do about what they're selling, those markets inevitably, quality deteriorates in them, and they inevitably become corrupt. And unfortunately, I think that's exactly what's happened to our healthcare system. It's become corrupted by the fact that the sellers have, that is the doctors and hospitals and drug companies and so on, have more information than patients do and always will. And even if the information were more equal, patients are often under stress, are scared, frightened, sick. They're not in a position to make a dispassionate purchasing decision as you would if you were buying a television set or a car or a computer. So this whole business about getting the consumers more skin in the game is total nonsense. And we have been sold a bill of goods by the corporate interests that are profiteering so handsomely from our dysfunctional healthcare system. So I think that we have to begin to look at these underlying pathologies and keep them in mind as we develop messaging to try to change the public dialogue. The framing of the nature of this problem has to be changed. This is not a problem of insurance reform and perfecting health insurance. It's replacing health insurance that is able to guarantee health care as a human right. That's what we need to do. So what are the barriers to reform? I mean, I've laid this out, and what are the barriers to reform? I'm a great fan of mnemonics, being a physician. It allows you to remember things you otherwise would prefer to forget. And so I've devised a mnemonic for the barriers to reform. I think of a fig. We bought some wonderful big giant figs in our recent visit to Vancouver just before we came here. And a fig stands for the 4 major barriers to reform among the American public. Apathy, I've got mine, not my problem, right? I have good health insurance, why should I worry about anybody else? Or I'm healthy and I don't encounter the healthcare system, so I don't have to think about it. Fear of change, fear that you'll lose what you have. There's a lot of insecurity out there. And fear of loss of income, fear by corporations of losing this golden goose that they're milking so effectively. So fear is a big issue. Ignorance, people don't know how the healthcare system works. They don't know that in other wealthy countries, people don't even think about money when they get sick because they prepaid. It's all done beforehand. There's a sense of political solidarity that comes from everybody belonging to the same system, so everybody has a stake in making it work. In contrast, here, we have dozens of different systems pitting one group against another. The young people against old people, sick people against well people, poor people against rich people, so on and so forth. So it's very important to begin to overcome that and understand that we're all in it together. And that's the way to do it. They also don't understand that it's actually cheaper, less expensive, fewer dollars, that is, to insure everybody than it is to spend a lot of money, time, and effort trying to figure out who not to insure. I recently did a column in the Bangor Daily News about what it's costing every resident of the state of Maine to keep some people from having health insurance. How much are you willing to pay to make sure somebody else has to grovel for their health care? And it worked out last year to be $1,500 a year per person, $6,000 for a family of 4, in a state where the average income is $35,000. And this column arose from a discussion I had with a plumber last winter. And I tried to explain to him how everybody would be better off if we simply expanded Medicare to cover everyone. And he said, well, you mean single payer? And I said, that's right, I do. And he said, I'm against that. And I said, why is that? I said, don't you understand that we're paying to take care of people anyway, whether they have insurance or not, but we're doing it the most expensive way? And don't you understand that it's actually cheaper? He could not be moved off of his position. And the reason was because I was talking facts to him, and he was reacting to his own fear and anger and insecurity. He said, I'm working my butt off, freezing my butt off, trying to find your frozen pipe, and I'm paying for my own insurance, and I don't want to pay for insurance for somebody who's sitting at home on their couch. I just don't want to do it. So I did this little calculation and said, well, okay, when are you going to want to do it? When it's $2,000 a year per person, $2,500, $3,000? What's it going to take? But I think I made the point, and at least made him think about it. I didn't change his mind because he was reacting emotionally. So that is something we have to understand. That we simply have to understand that there's a lot of ignorance there, not only about how healthcare works in this country, but when you tell people that folks in other countries don't worry about money when they get sick, it blows them. They can't get their mind around that, because that's all they worry about here. Healthcare is a leading cause of personal bankruptcy in this country. So, and then the G on FIG is good old-fashioned greed. There's a lot of money, $3 trillion a year almost in this system. Corporate profit, people are making money hand over fist. Corporate profits are high. There are lots of people who are performing administrative tasks or tasks as navigators or lawyers or consultants to help people figure out the complexity of the Affordable Care Act. Now, I'm not anti-Affordable Care Act. I think it was a remarkable political accomplishment given the nature of what's going on in Washington these days. And I give the people, Nancy Pelosi and Michelle Obama, Barack Obama, whoever pushed this through against resistance from this inner staff in the Congress and in the White House to get this done. But having said that, it's a pretty messy piece of public policy. It's not good public policy. It is unfair in the way its benefits are distributed. It is unfair in the way it's financed. And, later on the panel we can go into exactly how it's unfair, but it's patently unfair in the way all its goodies are distributed and the way it's paid for. And that has to be pointed out to people. And I think that we at Maine All Care are trying to do that by doing grassroots organizing at a local level, which you can do in a state with 1.3 million people a lot more easily than you can in a larger state, but nevertheless, that's what we're doing. So I think it's very important to change the framing of this discussion and to begin to think of some of the things I've suggested as ways to change the way people think about the nature of the problem. Where do we go from here? Well, I think the action is going to move to the states beginning in 2017. When a provision within the Affordable Care Act kicks in that says the states essentially can do their own thing as long as it doesn't cost any more and provides at least as many benefits as the ACA does. That was a provision that was authored by Senator Ron Wyden. And that's something that I think you're going to see a lot of states wanting to do their own things, very different things to be sure. But we'd like to see more states follow the example of Vermont, which has already passed a law taking advantage of this provision, saying we want to get to a publicly managed universal health care system in Vermont by the year 2017. And they've now set up a commission to figure out how do we get from here to there. Now, this is not easy. If this were easy, it would have been done a long time ago. But I think the next inflection point in this debate is going to be 2017 when the state innovations waiver provision of the Affordable Care Act kicks in. And states will have to apply to the government to get it done. They'll have to get permission from the Department of Health and Human Services to do it. But I think that's more likely. I'm not looking, and I'm sure Congressman McDermott has some thoughts about this, I'm not looking for a lot of dramatic action from Washington. There's just too much gridlock. The country is too heterogeneous to do it on a national level all at once. So I think we ought to look to the states to get this done. So, and forming coalitions at the local level and doing a lot of hard grassroots work is the way to do it. So we'll have a chance to talk more at the panel discussion. So that's it.
Representative McDermott, you're on.
Let me just say a couple words about single payer. I would second everything that the previous speaker said. And I want to just sort of outline where I think we are very quickly, and we'll get to it in the discussion later. I wrote H.R. 1200 back in 1991. Now, first of all, this health care reform business is not for the weak of heart or for those who want to live in a 24/7 world where everything is like this, like on your iPhone. This is something where you have to understand you are in a long, grinding battle. I had a meeting in this room in 1993 with Brock Adams, and our goal was to get a metro to the airport. It took us almost 20 years to get it. That's the nature of what you're doing here with healthcare. Winston Churchill once said, you can count on the Americans to do the right thing, but only after they've tried everything else. And we are presently in the trying everything else phase. And I think you should understand that. Those of us who backed the ACA was the best we could get. We got ourselves on the beach at Normandy, and we've been fighting the Huns who have been trying to drive us back into the sea ever since. 52 times, I guess, we've had repeal measures in the House of Representatives. It hasn't stopped. And there's no reason to believe, actually, in my view, that it is going to stop between now and the 2016 election. I expect the next 2 years will be perhaps more of the same, because they do not want this entitlement for all Americans, this right for all Americans to become a reality. And that is, they are absolutely dug in, and they're continuing to go at us. There are all kinds of things that should be done to make this thing work better. But I sit on the committee. I'm the ranking member, the ranking Democrat on the Health Subcommittee, the Ways and Means Committee, and we haven't had a single hearing on anything substantive the whole time. Not a single one. Not something we were going to fix to make it better. Always, how can we undermine it? How can we destroy it? How can we weaken it? That's only kind of hearings we've had. Just take one example. If you're somebody in this state and you go on to Medicaid for the first time, that's because your income is down here, right? And you're eligible for Medicaid. Suppose your income sometime during the year goes up. Well, then you go off Medicaid, right? Because you go month by month by month in Medicaid. So if your job holds up, that's fine. Now you go to the exchange and get yourself a plan, and then your income drops again, and you're eligible for Medicaid again. And people are going to be in this kind of situation. It's predictable. No, you don't have to be a magician or a great economist or anything else to be able to see that that's what's out there. Now, I believed when I wrote this bill in 92, that Tommy Douglas was right in Canada. If you understand Canada, Canada started in Saskatchewan. There were a bunch of farmers who had no money, and he was the prime minister, and he said, hey, look, all of us are so poor, we might as well throw all our money in together and take care of each other. That's how it started. It spread to British Columbia a little later. The doctors saw that it was working, and they thought maybe it would work there. And over time, it spread across Canada, and only at the end, 1967 or 68, they passed a bill that sort of tied it all together. It didn't start all in the capital, in Ottawa. It started in one province and spread to others. And you are seeing that in what's going on in Vermont. You've seen us try several times in this state to make it happen. You've seen people try to make it happen in California. And it is ultimately, in my view, going to happen one state at a time and everybody else. I truly believe that this business about governors turning down Medicaid is going to go in the wastebasket before the election, because Sally in California, who didn't have health insurance and got on Medicaid and has now had her knee replaced, is going to write a letter to her sister Bertha, who lives in Tennessee, and say, Bertha, guess what? We got health care and I got a new knee. My husband and I went out dancing. And Bertha's going to say to her husband, George, why don't we have that kind of health care here in Tennessee? And George is going to say, well, our governor doesn't believe that's good for people to have health insurance from the government. That isn't going to last very long. That's going to go down the tubes as time proceeds. But I believe that the biggest issue that this group should be thinking about right now is the 2015 session of the legislature in Olympia. Because if it's going to happen state by state, there's some stuff you got to get done down there. And you've heard that there is the possibility that state by state it can be done, and they're doing it already in Vermont. They're starting, and there are other places where it's beginning to percolate. And we couldn't even get a study in the last legislature. Now that means we got some work to do with members of the legislature, and they're up running for camp. You all got your ballot. You got my name on it, I'm sure. And if I could make no, I won't bother. But you should be looking at the people who are running and asking them about whether or not they would support moving forward on this issue. That ought to be something you go en masse and bug them about. And it really can happen, and I think that it is something that is really well within our reach, because when the people understand that the natives are getting restless, there's going to be some change. And I think that by 2017, we can be ready to actually do one. There's some things we need to do in Congress, and we'll talk about it in the discussion in the roundtable. Thank you very much.
Please join me in welcoming our council member, Shama Sawant.
Thank you, Sally, and thank you for your own work in 15 Now, without which we couldn't have achieved it. And thank you all, my sisters and brothers, for being here. I'm really honored to be able to speak in front of you, and I also thank all the esteemed speakers who came before me. I have a little bit of time to talk to you, and I thought we could start with just having a brief overview of what has happened as a fallout of the Affordable Care Act. And then I think we have to ask the most important question: why didn't we win single-payer health care when we were all mobilized to win, to fight for it? And obviously, that analysis has to lead to the next question: what can we do to fight back? And I'm really glad that Sally has framed this part of the conversation on the basis of 15 Now, because I think it holds a lot of lessons for us, general lessons for how to carry out a struggle for social justice. And if time permits, I would like to end by taking a global look at what is happening in general, but particularly for healthcare, because I think that our agenda of social justice, while primarily has to be geared towards winning single payer in the United States, also has to be informed by the understanding that these reforms have been fought for in other places. We had other speakers talk about other industrialized countries that have better healthcare systems, but what is happening to those systems is something that we have to think about, and that, in my opinion, as a socialist, leads to larger systemic questions. So I wanted to start by, in terms of the assessment of what has happened with Obamacare, by a quote from the National Nurses United, and I'm quoting from their March 2014, their most latest journal, National Nurse. It says, according to most reliable estimates, more than 30 million Americans will remain completely uninsured under this act, and many millions more will be underinsured as they enroll in lower-cost plans that leave them vulnerable to high deductibles and other out-of-pocket costs. And I think many physicians from PNHP have articulated really well our problem of not only people being uninsured, but the people who have insurance in name also being part of that segment that is suffering, and those are the underinsured, and that's pretty much everyone. And I'm sure you all recall Michael Moore's film Sicko, in which he starts by talking about people who are not insured, and then he says this film is not about those who are not insured. This film is about people who have insurance on paper, and what happens with the for-profit insurance. And going on about Obamacare, obviously there are some positive aspects, but it leaves most of the healthcare coverage in the hands of the employers, and it has strengthened the hands of private health insurance in administering coverage and setting prices and setting the terms for doctors and the hospitals providing care. And I need hardly tell you, many of you who are physicians and healthcare providers, what impact it has had. The U.S. is still leading the world, in terms of, especially in the industrialized world, in preventable death, infant mortality, maternal mortality. One of the speakers, I was struck by a previous talk that I had attended by the PNHP, in which the speaker, Dr. Andy Coates, who I'm going to quote again later on, who said that, if you look at simple measures of welfare in terms of health, how good is the quality of life, he talked about hearing aids. Hearing aids, given the technological advancement of human society today, cost next to nothing, and yet the provision of hearing aids is so difficult under our system, and it's not a commentary on how difficult it is to manufacture hearing aids, because it takes nothing. This is a question of political analysis. What is happening politically in our system? Why is it so difficult in the wealthiest country in the history of humanity that people who need hearing aids don't have access to them? And I'm using that as just one example. The list is practically endless. But I wanted to highlight some really key things about the consequences of not having single-payer healthcare, and I think our discussion should be formulated not on the basis of whether or not the ACA delivered something good. Maybe it did, but that's not the point. The point is, what are we not getting from it, and why didn't we win single-payer healthcare? That's what I would like to focus on. But just very quickly, we had a really great white paper from the IBEW, the International Brotherhood of Electrical Workers, who talked about how multi-employer healthcare plans have, for over 65 years, provided really good quality healthcare to a lot of unionized workers. There's been that history. And despite all their lobbying of the Democrats, they did not, and despite Obama's promise, the unions did not get what they were looking for, and the law is going to end up forcing millions out of multi-employer plans because small businesses are exempt from the tax on employees that do not provide health care benefits under the law, if we don't do something about it, that is. Let's also look, just some statistics at the extent and the spectacular growth of for-profit care. 52% of hospice care is in private hands. 77% of nursing homes are in private hands. 92% of dialysis centers, private, and 100% of freestanding lab image places in private hands. This is not a publicly provided health care by any means. The racial divide persists horrendously, The excess deaths, if you look at the excess deaths of the black community, more than 83,000 fewer black people could have died in 2000 if the racial gap had been eliminated. And future, the more recent studies are showing that that racial gap is persisting. I also thought it would be important for us to mention the recent Hobby Lobby case in Supreme Court. How could we talk about healthcare without talking about what has happened, the brutal attacks on women's reproductive rights? And in her scathing dissent, Justice Ginsburg said, the cost of an intrauterine device is nearly equivalent to a month's full-time pay for workers getting the minimum wage. And we have to frame this discussion not only in terms of the Supreme Court and the fact that there are conservative members in the Supreme Court. Of course, that is true. But had we won single-payer healthcare, this would not have happened. Single-payer healthcare is the only framework that guarantees affordable reproductive rights to women. And if we don't have a program that provides that for women, then this is not a country in the 21st century. That's right. And we also have to talk about the ongoing challenges in providing health care to the trans community. We need a guaranteed, publicly provided, affordable health care program such that the trans community members can go to any doctor and can never be denied health care. We cannot talk about health care as a human right unless we are talking about including everybody. So let's go on to the question of why didn't we win single-payer health care. Dr. Caper said, he listed some of the things that we face as barriers. What are the barriers? He talked about apathy. He talked about how the political formulation pits one group of people against the other. That is all true. However, I think that we have to understand the American psyche much more clearly than we are, than the narrative that we are handed down by corporate media. Single payer, or more generally, the idea of publicly provided health care and the idea of health care as a human right has always been popular among Americans. If you go to fair.org, Fairness and Accuracy and Reporting, they will show you a whole range of opinion polls, not just on healthcare, but every possible social justice issue. And if you look at the polls right from the Truman era, they will show you that the American public is well to the left of what the media will have you believe, and the American public is suddenly well to the left of the US Congress. You have to understand, it's a strange thing for me as an immigrant from India to be having to convince Americans that you're on the left. Don't believe the things they say about your own thinking. You are on. But I also have numbers here. A New York Times CBS poll from early 2009, this was when the public battle was raging, showed that the public preferred, by over 60%, public preferred a single-payer-like system over a privatized system. The public mandate exists, my sisters and brothers. That is not the barrier. The barrier in the battle for $15 an hour was not the public mandate. The public mandate kept growing with every new poll that was done. So what is it that is stopping us? I wanted to start, that analysis, to talk about the political strategies by mentioning how in 2009, and even leading up to 2009, the AFL, the National AFL-CIO, put all this effort, resources and foot soldiers into lobbying Congress for HR 676, Medicare for all, in the hope that this was going to happen under Obama. But what actually happened? Let's take, let's have a record of what happened. From the very beginning, the Republican strategists went on the offensive. The insurance lobby opposed the reform. even when it was obvious that it would enrich them, and there is a strategy behind why they did that too. They went around denouncing, what they call government-run insurance. Obviously, Fox News ran amok. They described it as un-American, socialist, treacherous. They were right about the socialist part. It's not treacherous, unless you are the pharmaceutical corporation CEO, in which case you would find it treacherous. They organized the Republican Party and the right wing. Systematically organized grassroots campaigns. They dominated town hall meetings many times, not always. Their message, which was reactionary and at times plainly racist, was heard loud and clear. And of course, the media played an incendiary role in this. And we all have this experience from campaigning in the state of Washington. Some of you I met during that time. And I remember, even if there was just one single person at a town hall or at a protest that was against single-payer healthcare, the media would just play that nonstop. And if you were at home, and all you had to rely on was a TV news report, you would think that the rally was, just full of anti-single-payer activists. So obviously the media played a big role. But what did the Democrats do? And when I say Democrats, please understand that I mean the Democratic Party establishment. There is any number of ordinary working people who consider themselves Democrats or Democratic Party supporters, whose values I share with as a socialist. I used to be a Democratic Party supporter until I gave up. Until I gave it up. Until I gave it up as a failed strategy. I teach statistics, among other things, in college, and in statistics, obviously, stats 101, if a hypothesis fails repeatedly, what do? You reject the hypothesis. You don't try to find more and more data sets that will fit the hypothesis. You try to find a different explanation. And so what happened with the Democratic Party? They controlled both the legislative and executive branches. They allowed the Republicans to dictate the agenda. Single-payer advocates were kept away from the discourse. The insurance industry representatives were given prominent seats at the table. I'm obviously not telling you something that you don't already know. If the insurance industry, and this is where the strategy part comes, if the insurance industry had embraced any of Obama's proposals right away publicly and called off their bitter campaign of resistance, then what would have happened? They would have allowed proponents of real change, of real single payer, enough room, some vacuum to organize and strike back. And they were very smart. The only way, they knew that the only way to avoid that was to keep the single-payer side on the defensive by denouncing even the most moderate change. That was the lay of the land at that time. And that strategy worked wonderfully. The louder their voice, the more the leaders of the Democratic Party were trying to appease them. And this is where the question of counter strategy comes in. If the Republican Party and the right wing and the corporations go on an offensive like that, what is the correct counter response? What is the correct counter strategy that is going to give you success? It is not what the Democrats did, obviously. What they did was they went on appeasing them more and more. Unfortunately, they did what they always do best. They silenced their left flank and kept moving the agenda to the right. And most of the progressives in the Democratic Party folded one by one, abandoning single payer or even the most meager public option. As you all recall, the last man standing was Dennis Kucinich, who flipped 2 days before the vote after Obama personally appealed to the voters in his district. Obama had no concessions to offer to the progressive side, but he got their vote. And from the Republicans, he failed to secure a single vote despite all the concessions. And so the Democrats managed, once again, to single-handedly pass legislation tailored to the needs of big business, much like the stimulus package of 2009, the bailout of 2008, and the credit card industry reform of 2010. And so the question here is not a question of morality or or the difference between Democrats and Republicans. Of course, we know there's a difference between Democrats and Republicans. The question is for us, as activists, what is our strategy going to be? Are we going to continue endlessly putting our eggs in the Democratic Party basket, or are we going to fight back in a much more challenging and defiant manner, having learned our Stats 101 lesson that this strategy of lobbying the Democratic Party and allowing them to water down everything that we fight for in relation to what they face with the Republican Party? Are we going to just continue doing that, or are we going to have an alternate strategy? David mentioned mass movements. I thought that was one of the most important phrases that has come up in our discussion so far. Of course, without mass movements, none of this is going to be possible. But we have to remember that in 2009, 2010, we did have a mass mobilization. We had a lot of activists out on the streets campaigning for single-payer healthcare. There were many who I personally met who were, young people who were getting active, politically active for the first time around that issue, because they had seen somebody among their family or close connections having suffered miserably because of the lack of real health care, and which, that just propelled their passion into that movement. So we did have mass mobilizations at that time, but we have to remember from that lesson that the mass mobilizations need strategies that will ensure us success. And that's where I hope that we can bring in the discussion of the $15 an hour movement. But before we do that, I think it's also important to mention some of the wonderful work that has been done all around the country by advocates for single-payer healthcare. Advocates for single-payer healthcare haven't admitted, defeated, and gone back. Obviously, that's exactly why we are here to discuss what we can do. The developments in Vermont are definitely worth mentioning, but I also agree with the description of the challenges that are being faced there. And we also have to make a mention of the valiant protests by nurses, by the California Nurses Association, and the NNU has played a fantastic role in this debate. But where do we go from here? Congressmember McDermott said that I think we're going to be able to win in 2017. I respectfully ask, why? How? What has changed? What is going to be different about the Democratic Party in 2017 that was not true in 2009? Why would they give it to us now as opposed to then? I don't think that anything has changed in the Democratic Party establishment except that they are watching what we're doing in Seattle. And so should we. We should be learning from our own success of the $15 an hour struggle in Seattle to understand what it is that worked. So what did we do in the $15 an hour struggle? How did that come about? Obviously, as many of you know, one of the starting points of placing $15 an hour as a concrete demand to build a movement around didn't happen overnight. It was, it's something that has to be tested, and then you have to have a feel for it. You have to have a sense that this is going to gain ground. This is going to capture the imagination of a large number of people. Obviously, as a socialist, I certainly don't believe that $15 an hour is enough. As an economist, I certainly don't believe it's enough. With a full-time job, it's only $30,000 per year. That is not enough to live on in Seattle, and those of you who live here will know what I mean. However, winning social reforms, making progress, winning progressive reforms is a question of how to bring out all the anger and the hunger for change into an organized manner, which is what we call mass movement. That is what a mass movement is. But for a mass movement to come together, which means that individuals have to be drawn in to a political struggle, we need a concrete political demand around which they can rally. Single-payer healthcare has that quality. It's a really viable, sharp, and wonderful political demand that we could build a movement around. We could rebuild that movement. But $15 an hour was exactly like that. But it had to be examined. So one of the most important steps that happened was fast food workers walking out. And I think one of the first walkouts was in Manhattan, just a week shy of Thanksgiving in 2012. That year, Socialist Alternative had run our first electoral campaign. We're activists, but we don't shy away from electoral struggle. We had run our first electoral campaign against House Speaker Frank Chopp. And we ran an openly socialist campaign. Our ballot said Socialist Alternative Party. And we ran an unabashedly working class campaign. We called for statewide single-payer health care. We called for rent control, affordable housing, and full funding for mass transit and education by passing a millionaire tax and ending corporate subsidies. And when we started our campaign, everybody told us, we're on your side, but there is no hope for this campaign. And of course, we didn't win, because otherwise I would have been in the State House. But we still won. We ran an openly socialist campaign. We took no money from corporations. We did not curry favor. We did not curry favor with the political establishment. And let's name the names here, right? In Seattle, Republicans are virtually a non-entity. So when I say political establishment, I obviously mean the Democratic Party establishment. And even so, we won 29% of the vote, which was 20,000 people voting for an open socialist, taking no money from corporations, and a socialist whose name they couldn't pronounce. I am facetious only in the aid of my more important political point, which is that none of those things mattered, because when people are hungry for a genuine alternative that is going to fight for them, going to appeal to their desire for social justice, then those labels don't matter. And in fact, not only was the label socialist not a barrier, people came up to me and said, if you believe in all these things and you're a socialist, maybe I need to read some of your literature. Maybe I'm a socialist, because it doesn't seem all that bad of an idea. But at that time, and the reason I mentioned that was our campaign had wound down, and we heard about the protests in New York, and the walkouts by fast food workers, by McDonald's workers, walked out with the demand of 15 and a union. And there was something that happened at that moment. I remember that we just felt $15 an hour is going to be the demand that people are going to be rallying around. And that is precisely what happened. Come 2013, we launched our socialist alternative campaign for city council, and at the same time, the labor movement went into struggle for $15 an hour at CTAC. A lot of these movement-like factors coalesced, somewhat coincidentally, somewhat consciously, but that is what we needed in order for this change to happen. And when we ran our campaign last year for city council, we had a very interesting development that happened. We had a group of people who are Democratic Party supporters who launched a Democrats for Savant group, because they have been fed up with relying on the Democratic Party establishment to carry out the values that they support them for, and they are hungry for a change. And that was one of the beginnings of the $15 struggle. After we won the election, which was, as you all remember, it was an unfolding drama in some ways, we quickly launched the 15 Now grassroots campaign. And as Sally Soriano correctly said, $15 an hour was being ignored by the political establishment of this city for the longest time. Roughly a month and a half before election day, election night, Ed Murray, who was at that time Senator Ed Murray, declared that he was going to be in support of $15 an hour, which was a very important development, and I welcomed that. But the reason it happened was not because the Democratic Party establishment was leading on this issue. Workers and ordinary people and activists led on this issue, and that is why the political establishment had no choice but to adopt that agenda. And the public mandate in this city came to a point where it was unviable for anybody running a political campaign, an electoral campaign, to not support $15 an hour. That is how we put pressure on the political establishment, not by lobbying them into perpetuity, but by challenging them defiantly and saying, we want to do this. Whether you like it or not, we are fed up with our falling standards of living. We are fed up with this misery that is inflicted on us, and we want a change to happen. If you don't want to be part of that agenda, that's your choice. And I think that that's the sort of defiance that we need in the single-payer struggle as well. And for those who might tell you that this is a divisive strategy, be courageous and tell them it's absolutely the most uniting strategy, because we are bringing all the working people together under one banner in order to fight for social reform. It is divisive towards big business and corporations, but it needs to be that, and I will never apologize for that. They will always tell you that you need to build coalitions. Of course you need to build coalitions. The question is not whether you need coalitions. Anybody who is even minimally politically savvy will know that you need to build coalitions, otherwise you're irrelevant. But the question is, whom are you building coalitions with? Right? Are you building coalitions with those of us who are permanently voiceless, to bring them into the political struggle, to engage them so that they will join this fight for their own rights? Or are we going to continue to build coalitions, or the so-called coalitions, with big business, with corporate interests? That is the question that we have to ask. And I think that question is relevant whether we are talking about a minimum wage issue, or a rent control issue, or a single-payer issue. Obviously, the details of strategy making and tactics will differ based on what demand you're talking about, which place and which time. But let us be willing to draw the general lessons of what Seattle has shown, what the Seattle working class has shown. That we need, for the working class, to break from this two-party system. We need a real push for building mass movements, but through those mass movements, creating our own leaders, having our own voices, running for office. I will say that the best way to ensure success, or to build for the success of single-payer healthcare in these statewide strategies that we're talking about, that Jeff Johnson is talking about, which I agree with, is to run single-payer advocates as candidates. People who will boldly say, I'm not going to take any money from corporations, pharmaceutical or any other corporations, and I'm going to fight for single-payer healthcare. Join me. I'm completely out of time, so we won't be able to. I just got the 1-minute card, so I have to respect that. It was 5 minutes ago. Well, let me just quickly talk about, we're correctly saying that, the United States has shamefully lagged behind other industrialized countries. There is no question about that. The healthcare systems, the healthcare delivery and access in many European countries and other countries like South Korea that was mentioned has been remarkably better. But I think that we also have to remember that as a fallout of this devastating recession, global recession, caused by the big banks and the hedge fund owners, has unleashed an unmitigated wave of austerity all over Europe. And one of the casualties of this process has been all the social programs that labor movements and workers' movements fought for in the past. I mean, European countries did not get healthcare systems, obviously, because their capitalist class is nicer than our capitalist class. They got it because, for a combination of reasons, the trajectory of social movements has been different, and they were capable of winning those gains. You know, they were capable of winning those concessions from the ruling class there. But what has been happening in Europe in the last 5 years is also a demonstration of why, even though we should be fighting tooth and nail for single-payer healthcare in this country, we should be well aware that every reform we fight for can be taken back from us as long as we accept the logic of this economic system, which is capitalism. So let's also have a broader and a more fundamental conversation about systemic change. Thank you.
Dr. White.
So I want to qualify a little bit, with all due respect, something Representative McDermott said about the Canadian system. He was correct in that by about the early 1970s, it had spread all the way across the country, and every province adopted a single-payer system. So in effect, Canada has, if you include the territories, 13 independent sort of single-payer systems. But the capstone occurred in 1984 when Parliament of Canada passed a very important piece of legislation called the Canada Health Act. And I'll just read a paragraph from that because it shows how in Canada, healthcare is considered a human right. It is hereby declared that the primary objective of Canadian healthcare policy is to protect, promote, and restore physical and mental well-being of residents of Canada, and to facilitate reasonable access to health services without financial or other barriers. And the Canada Health Act put in place 5 principles for healthcare in Canada, which are quite important. They are universality, accessibility, comprehensiveness, portability, and public administration. And the public administration, I think, is a really crucial one right now, because that means that both the funding and how the funding flows in Canada and the delivery has to be not-for-profit and not investor-owned. So as a psychiatrist, I'm most familiar, of course, with mental health care. Why does investor-owned mental health care compromise the right to health care? As Ms. Schmidt was describing, all the details involved in determining how something can become considered a human right, and accessibility and quality are part of that. So a study from 2003 in a journal called Psychiatric Services, on the basis of data collected since 1980, found that nonprofit, in the United States, nonprofit psychiatric inpatient care had superior performance on access, quality, cost efficiency, and amount of charity care compared with for-profit provision of mental health care. A 2008 study, after controlling for patient hospital and other covariants, when compared with not-for-profit hospitals, public hospitals were more likely to admit severely mentally ill patients than investor-owned hospitals. And then something I find particularly shocking and illuminating, a 2011 study looked at the relationship between the size of jail populations and the private share of hospital psychiatric beds. And they found that a 1% growth in investor-owned, for-profit psychiatric beds led to a 2.3% annual growth in jail inmates. So a single-payer system, as we have in Canada, can help reduce inequality, but it cannot eliminate it. And inequality actually probably has greater effects on health than what we do as doctors and nurses, et cetera. And if you want to learn more about this, I encourage you to read a very, I think, important book called The Spirit Level by Richard Wilkinson and Kate Pickett. And even though we have single payer in Canada, we still have lots of inequality, and we have inequity even in healthcare. There was a study of family practice clinics in Toronto in which people called clinics as sham patients, either saying they were an executive looking for an appointment, or they were somebody on welfare looking for an appointment. The executive's odds of getting the appointment was 1 in 4, and the person on welfare's was 1 in 7. So even though the doctors would be paid the same to see those patients, there's still something else at play there. I feel very fortunate, though, to be practicing psychiatry in British Columbia. I no longer deal with third-party payers, carve-out benefits, myriad formularies, and justifying my treatment plan to various bureaucrats. I run a provincial program for people with severe psychosis that is publicly funded, free of charge to my patients, and comes with a research budget. The mean length of stay is 6 months. I know of nothing comparable in the United States. So keep up your efforts for universal health care. Here in the US, and we'll keep up our efforts to defend universal health care in Canada.